Okay, we can probably at least start with our introductions and our explanations here. So we'd like to thank everyone for joining us today for our VCBH lecture series, our last one of the FY21 season. Just a few reminders for those of us joining us. We do have both our chat and our Q&A open. And we ask that you have any discussions in the chat box and any questions be posted in our Q&A. Dr. Galema will present for approximately 45 minutes, and we will take any questions at the end of that period of time. So please don't feel the need to hold your questions, but type them in the Q&A at any point in time during her presentation, and we'll address them at the end. I'm going to turn it over to the director of VCBH, Dr. Steve Higgins, and let him take it from here.
Great. Thanks, Nicole. So I want to give a hearty welcome to everyone to, as Nicole mentioned, our final series in the spring lecture series. I'm especially excited because we have one of our own VCBH investigators and faculty, Diann Gaalema, presenting. Diann is really a key member of our center. She is a graduate of our T32 program and active in the center grants that we have, and especially active in a research area in collaboration with Dr. Phil Ades in secondary prevention around cardiology, and that's the focus of her talk today. So I'm going to turn it over to Phil to do an introduction on that topic area. Thank you.
Okay, thank you, Steve. I'm honored to introduce Diann Gaalema as our monthly speaker for the VCBH lecture series. The title of her talk is Secondary Prevention of Heart Disease, a focus on smoking and socioeconomic status. And this is a topic that brings together three important areas of focus of the VCBH: tobacco use, behavioral economics, and vulnerable populations. I first met Dr. Galema back in 2011, it was, Diann, when Steve and I were putting together our first application to NIH for a COBRA Center grant on the topic of behavior and health. The key was to find 5 young investigators of great potential as project directors, because we would largely be graded on whether we could train young investigators to get their own federal funding. Working as a team with Steve and I as mentors, Diann put together a study blending our expertise in 2 different areas on the value of financial incentives on increasing cardiac rehab participation in lower SES patients. And I'm sure she'll speak about that study today. She not only completed that study with really exciting findings, she got it published in a high quality journal, the Journal of the American College of Cardiology, which is our highest impact cardiology journal, and subsequently was able to fund a much larger study with an R6133 grant from the NHLBI, which is ongoing and keeping us all very busy. Diann's education includes a bachelor's in psychology from Arizona State, 2003, and a master's and PhD in experimental psychology from Georgia Tech, with her dissertation on the very relevant topic of sexual conditioning in the dying dart frog. That was in 2010. I'm sure you'll take questions on that. She subsequently did postdoctoral work here at UVM with Dr. Higgins, starting in 2010, and came on faculty as an assistant professor in 2012. She's now an associate professor with over 80 publications. Of areas of expertise have included smoking behaviors, behavioral economics, and behavioral aspects of cardiac rehabilitation, and she really has become a national expert on that topic. With great pride, I introduce Dr. Galema to our national audience as a featured speaker in our lecture series and as one of our great success stories. Diann.
Phil, you're killing me. Try not to cry over here. But thank you, Dr. Ades and Dr. Higgins, for that very kind introduction. And I really do appreciate the opportunity to come and present as part of the lecture series. So I'll go ahead and get set up here. All right. So as I was saying, I'm very happy to have been invited to be part of this lecture series. And I was thinking about it as here I am in the spot of the last lecture series of the year before we break for the summer. And that makes me reflect back on the last year and what a year that has been. So when I was thinking about what I wanted to talk about, it was also making me feel rather reflective. And I thought I would talk about kind of the progression through the research space that I've had over this last, as Phil mentioned, 10 years now. So I switched the title a little bit to go from secondary prevention of heart disease, focus on socioeconomic status and smoking, to more of the journey that we've been taking through SES and smoking. So just to get my disclosures out of the way, I've been fortunate enough to be funded by several external sources of support during my time at University of Vermont. And accordingly, what I share in here is not necessarily the views of NIH or FDA. And other than my grant funding, I have no other conflicts to disclose. All right, before I kind of dive into how this field has developed in my research in it, just wanted to introduce a couple of terms so that make sure that you're all on the same page as we dive in. These are three things that I'll talk about throughout the entire presentation, so wanted to be clear about them. So as Phil mentioned, we talk a lot about socioeconomic status. So this is reflective of someone's economic and social position in relationship to others. And there are a variety of ways to measure it. Some of the common ones are educational attainment, income, insurance type, occupation, or some combination of those factors. But this can be really reflective of people's access to resources within their community. I'm also going to talk a lot about smoking, and for the purposes of this talk, that's going to be mostly specifically to combusted tobacco use and generally talking about conventional cigarettes. And the theme that really ties this all together is the idea of secondary prevention. So this is the idea of trying to reduce the impact of already established disease. So when we're talking about cardiac disease, there are several things you can do to improve secondary prevention, improving health-related behaviors such as smoking cessation, increasing physical activity, changing diet. But there's also a specific program, clinical program, that is geared towards secondary prevention, and that is cardiac rehabilitation. So I thought it was interesting that Phil shared how long ago we met and how this all started, because I definitely have a similar viewpoint of how things started. So this is, for me, where really this kind of journey on secondary prevention and socioeconomic status started, is that I kind of envisioned it that it went this way. Dr. Ades and Dr. Higgins were on a run somewhere together and talking about their various forms of expertise, with Dr. Higgins talking about socioeconomic status and health behaviors, and Dr. Ades talking about secondary prevention of cardiac disease. I'm thinking about how those things blended together. And then at some point, Dr. Ades goes off and thinks about, well, let's look at participation rate in secondary prevention, my expertise, pulls up values on state level cardiac rehab participation rates, state level high school graduation rates, throws it into an Excel file and gets a surprisingly high correlation. So Dr. Ades and Dr. Higgins get together, look at this, and bring me in and hand it over and say, look at this. We got disparities by SES in secondary prevention. You should really run with this. So at least looking back on it, this is really kind of where this whole research area started for me. And I'm quite happy it did, because I found this to really reflective of the experiences I've had going forward, is that we've had this really collaborative, productive research group that has blended, the expertise from the University of Vermont and the clinical expertise available through the University of Vermont Medical Center. And through that collaboration, we've really been able to produce some nice research in the areas of secondary prevention and SES. All right, so just to step back a little bit and talk about the larger issues of disparities in cardiac disease. So I know that I had mentioned talking about cardiac rehab specifically, but when we're looking at disparities and socioeconomic status, it's clear that these disparities touch all points of disease progression. So if you look at differences by SES, this starts at disparities in development of disease. Lower SES patients tend to have higher risk cardiac profiles that are characterized by higher rates of smoking, comorbidities such as diabetes, low levels of physical activity. And so this speeds progression of disease. And then when we see these acute events, like for example, having a myocardial infarction, we see worse prognosis following these events in those of lower SES. So one example, if you look at mortality rates 1 year following one of these acute events, the mortality rate can be more than double of that in the lower SES patients as compared to the higher SES ones. And so when we talk about disparities in cardiac disease, it's clear that it's there from development and in outcomes. And then, so our focus then is looking really at the disparities in secondary prevention. And I just want to touch a little bit about why this seems to be especially important. So when we talk about health disparities, when we think about these different groups, we can think about on a baseline, if we have a higher SES group and a lower SES group, that baseline, the higher SES group is probably participating in more preventative behaviors than the lower SES group. So here's our existing disparity. But the issue is if we have a major health event and then the response to that is disproportionate, like if the higher SES group is changing their behavior more to compensate for having had that health event, then we see that this disparity widens. So this is not only an issue of disparity, but of potentially exacerbating existing disparities. All right, so talking about secondary prevention, we can talk specifically about cardiac rehabilitation. So cardiac rehabilitation is a medically supervised structured program that is used to improve cardiovascular health following one of these qualifying events. So some of the events that are covered by insurance include having a recent myocardial infarction, bypass surgery, getting PCI, various types of heart surgery, and also some types of chronic heart failure. So the components of cardiac rehab, it's generally an outpatient rehabilitation program where people attend 1 to 3 visits per week over a period of about 4 to 6 months, and most insurance covers 36 sessions. So the components really are a combination of supervised progressive exercise that is meant to build up cardiovascular fitness, combined with ongoing symptom monitoring and educational opportunities on other areas of secondary prevention, such as medication adherence, changes to diet, improvements in physical activity, and management of stress. So cardiac rehab is an extremely effective secondary prevention program. So for those that attend cardiac rehab, it's highly effective at reducing morbidity and mortality rates. You can see a 26% decrease in cardiac mortality over a 3-year period and a 31% reduction in cardiac rehospitalizations over a 1-year period. And so the issues that we see going into this is that we have a really great program that does really well, but not everybody is attending. So here we have CR attendance rates, they're not ideal. We know that less than half of those who are eligible in the US and Canada actually participate in cardiac rehab. And that's people that show up for even 1 session. If we look at whether people attend the whole span of sessions, which would be the ideal, the more cardiac rehab you do, the better your outcomes, that dropout is also an issue. So this is when we can bring it back to looking at the disparities and looking at participation specifically in our disadvantaged populations. So we know that CR attendance overall is an issue, and that issues become even more pronounced when we look in the lower SES populations. So this is just a couple of examples of how we see those disparities. So starting with looking at some claims data, it's older now, it's from back in the 90s, but if you looked at all the Medicare claims, this is work done by Soya and colleagues, if you look at all the Medicare patients, these are people 65 plus, and look at the claims data, only 18% of those who are eligible for cardiac rehab attended. But if you look at the ones that were Medicare, Medicaid dual eligible, so these are our lower SES folks, only 3 to 5% of them attended cardiac rehab. And then I have also just this example of just what I found to be a very stark illustration. There was one study looking at every single Medicaid patient in the state of Washington who was discharged following an MI, and there were 322 eligible Medicaid patients, but only 2 of them, so it's less than 1%, attended cardiac rehab within their year following their MI. And we see this on national level as well. If you look at survey data, for example, you see disparities in attendance at cardiac rehab, with, for example, those with lower levels of educational attainment, at least a third less likely to attend cardiac rehab. So all of this, suggests to us that looking at disparities in cardiac rehab participation by SES status is likely an important issue. So one of the first things that we did was to do a chart review locally and see if we could replicate this issue as well. So that was one of the first things we did. We looked at all the people over about, I think it was a year and a half, that were eligible for cardiac rehab and split them by insurance status and found that indeed, if you look at the commercially insured people, about 46% of them participated in cardiac rehab and about 35% completed the whole run of cardiac rehab. But if we look at our Medicaid, our lower SES population, we see half the level of participation, and then the percent actually completing the whole program drops to 8%. So one of our first tasks then was to try and figure out a way to improve cardiac rehab participation among these lower SES patients. So Phil touched on this, that this was my COBRE project from when I was one of my first projects as early career faculty. And what we did was use a behavioral intervention that had shown to be effective in other vulnerable populations and health-related behaviors and translate it into cardiac rehab. So the intervention we were using was called Contingency Management. It's also known as the use of financial incentives. And the idea here is that you promote behavior change by immediately reinforcing objectively verified behaviors. So someone performs the behavior you're looking for, whether that's cessation of smoking or attendance at cardiac rehab, that behavior, once objectively verified, is immediately positively reinforced. And so that positive reinforcement of that behavior helps maintain that behavior over time. And we know that these treatments have been really effective in other disadvantaged populations. So for example, if you look at smoking cessation in pregnant smokers, the use of incentive is significantly more effective than any other behavioral or pharmacological treatment that has been used. And one of the nice things about use of incentives is that it's really good at increasing completion and adherence rates, especially for behaviors around attendance. So if you looked at compliance with other types of behaviors, it's been used to, the incentives have doubled completion rates in other areas. So what we did is we took 130 cardiac rehab eligible Medicaid insured participants and randomized them to either earn incentives on an escalating scale for completing those 36 cardiac rehab sessions or to a non-incentive control. So as Phil said, this was a very successful project. Our participants in our incentive condition, they earned on average about $700 over that period of 4 months, and they completed significantly more cardiac rehab sessions, so 22 versus almost 15, and more importantly, they were almost twice as likely to complete. So here you can see the dropout in our incentive group versus our non-incentive group, and almost twice as many of our incentive group finished all 36 sessions. So this is exciting, but one of the things that we really hope with being able to get people into cardiac rehab is that this will translate into health outcomes. And while we weren't powered to actually look at the hospital outcomes in a way that we can, report on them, we did get some initial data that seems to be very promising in that regard. So this is just looking at kind of our healthcare utilization data from that first study and looking at cumulative ED visits and hospitalizations among the two groups. And you can see that they're over time, in the year following being entered into the trial, that we get good separation in both ED visits and hospitalizations. And one of the things I wanted to also touch on is, like, specifically, you can look at what type of visits people are going to the ED for. And where you would expect to see differences is where you do the people who are in the incentive condition and thus are probably engaged in cardiac rehab are less likely to go to the emergency department for cardiac related issues. And this makes sense given that when they're in cardiac rehab, not only are they having their cardiovascular fitness improved, they're also getting ongoing guidance on how to manage their symptoms and which symptoms they should deal with and what ways. All right, so as Phil mentioned, then we After completion of that study, we successfully secured funding to expand our efforts, and we are currently in the process of recruiting 200 more lower SES patients who are eligible for cardiac rehab. We're over halfway done at this point. Same thing, looking for people that are eligible for cardiac rehab and engaged and insured through Medicaid or have a less than high school education as another marker of lower SES. And we're randomizing them into 1 of 4 conditions, so usual care, incentives, so this is like the prior study. And this time we're also adding an arm about case management to look at whether another intensive intervention can also be effective at improving participation in this high-risk group, or if the combination of 2 intensive interventions can provide even better outcomes. And I wanted to touch on why we were looking at case management. I mean, we know from other studies that the challenges of lower SES populations are really quite diverse, and the kind of needs and issues that are going on can really interfere with their ability to manage disease. So as part of what we do as case management is really ask them and do this comprehensive needs assessment to find out what it is exactly that is keeping this population from being able to engage in self-care. And these can just run the gamut from medical. I mean, are there other medical comorbidities that are keeping people from engaging in cardiac rehab? Are there social needs? A lot of our patients, for example, may be taking care of other people in the home and feel like they don't have time to focus on their own disease. Psychological issues of anxiety and depression are definitely issues with being able to access cardiac rehab. And then just like the practical needs that people run up against of, are there issues with transportation? Are there issues with affording your medication? Is your housing situation unstable? What are just the practical needs that people are dealing with that are keeping them from appropriate self-management? So our case managers are also available as needed to answer kind of acute needs, and also serve to check in with people weekly to encourage them to reach treatment goals. All right, but attending cardiac rehab is not the only secondary preventive behavior. So this is just kind of another area that we branched off to. And what we wanted to do was really look at behaviors more generally after one of these acute cardiac events and whether we'd see disparities by SES. This goes back to where I was talking about that inflection point, and do we see further evidence that those disparities are going to increase even further? So one of the approaches we did to look at this was to do a systemized review, looking at studies that are reported on change in behavior following MI and looking at it by a measure of socioeconomic status. So we identified 44 studies across 5 behaviors that you would hopefully engage in after a myocardial infarction: CR attendance, medication adherence, change in diet, change in physical activity, and smoking cessation, and see how they differed by MI or differed by SES. So this is what we found, is that across all of these behaviors, the preponderance of evidence in the existing literature is that yes, there is less behavior change for those lower SES populations, and this was across all 5 of them. And so I just want to bring your attention to one of the ones that sticks out here. I mean, some of the best evidence is for cardiac rehab attendance, and so obviously that's a huge disparity we see post-MI, but smoking cessation also showing evidence of differing by SES, and definitely very important for other reasons. So on that note, I just want to switch over to smoking. I will say that even in this existing studies where we were examining SES and secondary prevention, smoking just keeps coming up. I mean, I do other research that's related to tobacco use, so I probably would have gotten pulled into this anyways, but every time we're working with these patients, lower SES patients, smoking keeps coming up. So for example, prior to starting our studies, I think the cardiac rehab program, the current smoking rate of people coming in was maybe 8% or something like that, relatively low. And then we start bringing in the Medicaid patients and getting them to engage in cardiac rehab. And the current smoking rates for the patients in those studies is 30 to 40%. So it's obviously, if we're going to talk about secondary prevention and talk about issues of SES, then it's important that we talk about smoking as well. And one of the obvious reasons why it's important to talk about smoking when we're talking about secondary prevention is just the very large role that smoking has in coronary heart disease. So I'll just briefly go over this, but the dangers of smoking to the cardiovascular system are well known. So combusted tobacco use results in endothelial dysfunction, blood vessel constriction, platelet activation, chronic inflammatory state, dyslipidemia. And this leads to a variety of outcomes: acceleration of atherosclerosis, destabilization of coronary artery plaques, and these precipitate acute coronary events. So as you might expect then, when people look back at 50 years of smoking, it's estimated that this history of smoking has led to close to 8 million premature deaths due to cardiovascular and metabolic diseases. And estimates for the risk ratios of smoking is that it increases risk for mortality, for coronary heart disease mortality by 2.5 times in men and even closer to 3 times in women. So, and then it's not just about the development of disease that's important here. So when we're talking about secondary prevention, continued smoking is the #1 predictor of having a subsequent event. It is the most powerful predictor of whether a person will go on to have another myocardial infarction or need another bypass surgery. And what's really interesting about this is that those that have cardiac disease are really well aware of the dangers of smoking. Smoking and heart disease, I mean, smoking is one of the most recognized modifiable risk factors, both in the general public and in patients as well. So it's not like this is a surprise to anyone that this is an important behavior that should be dealt with. And consequently, people who are successful in cessation are going to benefit immediately. So someone who was a smoker and has an event, if they quit smoking, you see a reduction in the recurrence of coronary events to that of a non-smoker within 3 years of smoking cessation, and you reduce your mortality following a myocardial infarction by half over 3 to 5 years. The problem, though, is that successful cessation is really difficult for this population. It's estimated that even with treatment, if you follow patients that were hospitalized for cardiac issues and you give them treatment and you follow up with them 6 to 12 months later, 75 to 85% of those patients will have relapsed. So this was kind of an opportunity for us to look at a different set of data to try and learn more about the issues of smoking and those with cardiac disease. So this, we went and switched it up a little bit and went and looked at some epidemiological data using the PATH study, which is a very nice data set that has this longitudinal national level data set that has a focus on tobacco and nicotine use. So you can use it cross-sectionally to look at certain things, but you can also look at things longitudinally. So we started examining this data set, looking at the 23,000 that were available at the beginning, that could be characterized by their health status, and split them into, we categorize either people into those that had major health event and those who had a lifetime MI, and sorted out the people that had other major life health events. And looked and characterized them on tobacco use and also attitudes towards use of those products. And so looking at that initial wave of data, among those who reported having a lifetime MI, first of all, they were more likely to have been a current or former combusted tobacco user, which is good to look at. That shows that we are looking at the right stuff. But these people that were current smokers with lifetime MI, they were also more likely to believe that smoking or using tobacco was causing or worsening their health issues. So once again, just evidence that they were not unaware of the dangers of smoking. So then what we could do is use this same data set to look at changes over time. So we have this initial set of data, and then they're followed up 12 months later. So we can look at all of those folks and look at the ones that didn't have anything happen in that last 12 months health-wise, and to compare them to the people that reported having a new myocardial infarction in that time period. So when we look at that, we have 240 people that reported having a new myocardial infarction between the waves, and we can examine the changes in tobacco use in that group as compared to those who had no similar major health event. All right, so when we look at those individuals with a new MI, we see that what they do is we see a higher odds of attempts to either quit or reduce their combusted use. But surprisingly, what we don't see is that having that MI is not a significant predictor of either successful cessation or even of a change in CPD in 6 per day. So that having that event on its own is not enough to significantly change smoking. All right, so talking about, obviously now we've talked about how smoking is an issue and the challenges with smoking. I also wanted to draw this back a little bit and talk about smoking kind of like the way I talked about SES and how smoking relates to other health-related behaviors. And so I'll go back to another epidemiological data set. But one of the things that I've learned, if I've learned anything over my years and years in behavioral research, is that a good rule of thumb is that health-related behaviors predict other health-related behaviors. And so I was interested to see if we could duplicate that with current smoking. So for this, we looked at a data set called the BRFSS and another national level survey. And this allowed us to characterize about 26,000 participants who had reported having had a lifetime MI and characterize them by smoking status. So here we compared, current versus former smokers to try and take out a little bit of the variability. And we're not comparing the current smokers to the never smokers. But even when looking at the current smokers versus the former smokers, those current smokers were more likely to report these other health-related behaviors, significantly more likely to report all of these, what we consider not good health-related behaviors. So not taking their medications, problematic drinking, getting no physical activity, not ideal diets, and also not attending cardiac rehab. And another thing we looked at when we were looking at this data was just kind of how these different behaviors cluster. So it was interesting to us to think about, what do we see as far as smoking behavior predicting other types of behaviors. So the thing I want you to look at here is you just look at the never smokers up here who have no risk factors. Most of them have no other risk factors. So this is the most common thing for this group to be, is to have none of these risk factors. And we look down here at the current smokers, who by definition have one risk factor with smoking. And the most common thing for them is to have an additional risk factor. So they're dealing with current smoking and no physical activity, or current smoking and poor diet, or current smoking and problematic drinking. That those factors are clustering together. And I will just have to throw in here that, of course, we are not forgetting about SES, even when we're talking about smoking and behavior. And here's just an example of that. So these are, once again, looking at those number of risk factors or negative health-related behaviors. And if you look at it by within those with college graduates, that they are, much more likely to be in the 0 risk factor and decrease as the number of risk factors increases. All right, so just to bring this back to cardiac rehabilitation, as I mentioned earlier, cardiac rehab is a fantastic program for secondary prevention and very effective at reducing morbidity and mortality. So what happens with those who are current smokers in cardiac rehabilitation? So one of the first examinations we did on this was to go back and review the literature and just see what was the existing evidence on the effects of smoking status on various aspects of cardiac rehab. So we did a systematic review looking at the effects of smoking on 3 parts of cardiac rehab: whether people were referred, whether they attended, and whether they completed cardiac rehab. And we included 56 studies in this. And it was interesting that to see along referral, there doesn't seem to be any sort of disparity. Current smokers, if anything, were more likely to be referred to cardiac rehab, but current smokers were less likely to attend cardiac rehab. And the data was especially clear on dropout, that those current smokers were much less likely to complete cardiac rehab than non-current smokers. And this is just a summary table of the studies that were included in that dropout outcome. And I just wanted to show you, so these are all the studies here where current smoking was associated with dropout. And I just find it striking that these are across many different years, many different countries, different sex distributions, but across all this variability, this was a very consistent finding, is that current smokers were much more likely to drop out of cardiac rehab. So we've also looked at this locally as well on the effects of current smoking and cardiac rehab participation. One of the things that I really enjoy about working in collaboration with the medical center is that there is a wealth of data that I get to play around with. And one of those is the research database that the cardiac rehab program at University of Vermont Medical Center established decades ago. It's a carefully curated database. Thank you, Patrick and Phil, for starting this. Allows us to have decades of data and look at what the characteristics of those who enroll in cardiac rehab and a lot of other wonderful outcomes to look at. So I was able to look at this and look at the clinical and demographic characteristics of patients enrolled in cardiac rehab and the number of sessions that they completed. So for this analysis, we used a card analysis, classification and regression tree, which really just allowed us to sort out these different patient characteristics and look at which of the factors were explaining the most variance in number of sessions attended, and also looking at the effects of combinations of those factors. So here is just the full cart tree, which, don't worry about excessively, but it is interesting to see how combinations of risk factors lead from an average of 9 sessions attended to an average of 27 sessions. But to focus on the smoking, so you can see here, these 2 red circles are, when we get to this point, if someone's a current smoker, then they complete 11 sessions. If we get to this point, they complete 19 sessions. So a difference of 8 sessions, depending on your current smoker or not. And we see the same thing over here. If you're a current smoker, 16 sessions completed, not current smoker, 24 sessions completed. So just that current smoking status is predicting a difference of 8 sessions completed. So looking at overall, what can we say about smoking in cardiac rehab at this point? We know that smoking is a large driver of cardiac events, and we also know that current smoking is a risk factor for not attending or completing cardiac rehab. Smoking is also a risk factor that is addressed in cardiac rehab, but if we look at programs nationally, CR programs generally are not terribly effective at promoting cessation. So for me, this was another area of interest of what can we do to improve tobacco cessation in cardiac rehab programs. And one of the ways that we could do that using our collaborations and our existing strengths and research around tobacco was to help at least with improvement of the measurement of tobacco use. So most programs, when asking about smoking in their patients, rely on subjective report or on hospital records. And there are very, very few, if any, cardiac rehab programs that are objectively measuring smoking status. So this is one thing that we were able to do collaboratively to improve the clinical program. All right, so talking about carbon monoxide monitoring in cardiac rehab. So as I mentioned, we've got the University of Vermont Medical Center cardiac rehab program that's serving our local area. And they enroll about 500 patients per year. And what we did was implement objective carbon monoxide monitoring. So exhaled carbon monoxide is a measurement that is sensitive to recent smoking of combusted tobacco. And by using CO monitoring, you can get an estimate of, you get an objective measurement of someone's smoking status. So we were able to provide the cardiac rehab program with a couple of CO monitors, and they figured out a way to get it implemented and started screening people in April of 2018. So when we looked at this data, they had screened 853 patients for carbon monoxide, and were able to look at the demographics of those patients as well as the clinical characteristics. And this gave us the added benefit of being able to look kind of at the discrepancies between what you see as far as self-reported smoking status and objective smoking status, as well as characterize the patients by their carbon monoxide levels. So this is just demonstrating the relationship between those different measurement types. So here's people self-reporting current smoking. Here are people self-reporting former smoking, and here are people that had a carbon monoxide measurement of 4 or greater. And so what we're really interested in is this group here who had reported being former smokers. They were at risk of either continuing smoking or resuming smoking. And so we identified 44 people here that needed to be looked into a little closer. And interestingly, a subset of these folks were further queried by the clinical staff, and at least like 18 of them reported they were using some form of combusted tobacco, and then an additional 5 had reported exposure to secondhand smoke that was possibly resulting in their elevated CO levels. So it was useful for able to find people at risk and being able to further intervene. And to look at the patient characteristics by carbon monoxide level. So you can see here those who had the higher CO levels, they're younger, which makes sense. Combusted tobacco use is accelerating the age of development, or accelerating the development of cardiovascular disease, so they're going to come into cardiac rehab sooner. We see big differences in educational attainment. And we also see higher levels of depression and fewer sessions of cardiac rehab completed. So once again, just demonstrating the higher risk group that current smokers are in cardiac rehab. Another thing that I found really interesting is that even though these patients are coming in younger, they also have very similar fitness levels. So fitness tends to decrease as age increases. So for them to come in younger but have the same level of fitness is not what you would expect, and suggests that current smoking is interfering with their cardiovascular fitness. So this is just what that looks like as a general trend. We've got all the orange dots are those who have a less than 4 parts per million CO, and the darker blue dots are 4 or greater. And these are just the trend lines looking at fitness measured by peak oxygen uptake as compared to age. And as you can see, general trend is that fitness decreases as age increases, but you can see from the trend line here that those who have the higher CO measurements, that line is shifted downward, that they have lower level fitness than would be expected given their age. And just some of the takeaways from this work that we did is that it does really highlight, once again, that these current smokers are at high risk. They have, of course, the health effects from continued smoking, but they also have higher levels of depression and impaired cardiovascular fitness, which is closely tied to future events. And another thing that we found is that once we got the screening implemented, that it seems to be relatively low burden and it's highly acceptable to patients. Last time I asked, nobody had refused to be screened. And then also our results suggest that we might be missing a substantial number of patients by relying on self-report. So being able to objectively measure, objectively identify people in need for follow-up is important clinically. And one of the other benefits that I heard about is that, at least that some of the staff reported using the CO monitors to help with goal setting for people that wanted to attempt smoking cessation while in cardiac rehab. So this was kind of an ongoing measurement that they could use those CO measures to have objective evidence of their efforts. So if they cut down, then their CO would come down. And so it was just an extra way in which the CO monitors could be beneficial to the program, which I was happy to hear about. All right, so just to summarize, the smoking in those with cardiovascular disease is very challenging. Continued smoking is the #1 predictor of subsequent events. Smoking is a huge predictor of non-engaging with secondary prevention, and cessation is obviously very difficult. So to me, this suggests that we have this need for better treatment. So this is really the research space I find myself in right now, is that I see this issue of smoking in cardiac patients, and it needs more attention. I mean, there's some existing evidence of attempts to address these issues. And one thing we know is that brief or low touch interventions are really ineffective in this population. If you give advice to quit, you provide self-help quit materials, you do follow-ups at post-hospital visits. These are ones that tend to happen 4 to 6 weeks after hospitalization. these have some short-term benefits on quit attempts, but if you follow up a year later, you're not seeing any differences in smoking rates. So there have been some attempts at more intense interventions that have shown some promise. If you intervene during hospitalization, you put serious time into discussing with the patient ways to improve cessation, if you do regular follow-up calls for at least 1 month, then that does at least move the needle on quit rates. But for me, this seems like an area that's really in need of more research, because we have this problem space that's very interesting. We have most of these patients who are abstinent from smoking while inpatient. They're motivated to quit because they've had a recent cardiac event that they know is tied to their current health status. But the issue is that for the most part, these patients don't get seen again for 4 to 6 weeks. They leave the hospital and nobody follows up with them. And that we know from other research that the median time for someone to relapse from after they leave the hospital is 1 to 2 weeks. So I just want to leave that as kind of like having journeyed through SES and secondary prevention and tobacco. This for me is really seems like an area to focus in. All right, so just to sum up my that whirlwind journey through my research the last 8-9 years, disparity in development of and outcomes from cardiac events is present both by socioeconomic status and by smoking status. And these factors are also predictive of engagement in secondary prevention. So while our ongoing studies have shown that we are making some progress in improving engagement in cardiac rehab among these high-risk groups, smoking continues to be a really vexing issue that is in need of more intense intervention. All right, there's some of my references, probably not all of them, but I'm happy to share with anyone who wants to do a follow-up. And that is it. Happy to answer any questions.
Okay. Well, after great applause, which I can hear, we'll take questions, and I do see one question in the queue. So the first question, did you look at reported use of illegal drug use, either in regard to smoking or cardiac rehab? The study I work with is composed of current and former IV drug users, and approximately 80% are current smokers. I would think that drug use could certainly interfere with a person's ability to engage in rehab.
And I will say in our existing clinical work that we do not test or routinely ask about use of illegal substances. We definitely do get many reports of marijuana use when we ask, because we talk about combusted materials and we ask about everything they're smoking. So we hear a lot about marijuana, but no, we don't routinely ask about that. And yes, use of substances such as cocaine and heroin are huge issues with engaging in secondary care, and we see that elsewhere. And I know that there are indeed programs that specifically will not take people that are active users for fears of not being able to deal with them clinically while in cardiac rehab. I don't know, Phil, if you all have a.
Well, I can add that in my 37 years of doing cardiac rehab, it's been well known, for example, that cocaine use can accelerate coronary disease and has its own type of coronary disease. And those patients don't generally come to cardiac rehab, just like smokers don't come to cardiac rehab. They tend to be much younger. They probably feel like they don't fit in. And one of the pushes in the latter part of my career that I want to transfer to younger folks is we should be thinking about prevention for people who don't come to cardiac rehab. We need to be looking at ways, coming to cardiac rehab sort of divides you off right from the start as being health oriented. And we need to get something to the people who don't come, who are high risk. And I think a lot of drug users, cocaine users, to a lesser degree, marijuana users would fall into the category of people who don't come to cardiac rehab. Yet they're more likely to get admitted, so they're high risk. Yeah.
I can add, we do, as part of our ongoing studies, we enroll anyone who is eligible for cardiac rehab. And one of the criteria that makes you eligible is having valve surgery. And many of our valve surgeries result from use of IV drugs. They
Yep, good point.
cause infections, which cause need for repair. And I will say that yes, we do find that engaging those patients is incredibly challenging. That we recruit them, but they are one of the ones that we very rarely see actually make it into the program. There are some exceptions, but that does seem to be a pretty striking difference. And I'll mention too, I'm not sure if it's the cause for this, but one of the other really interesting factors that we see in cardiac rehab participation is age. The younger folks tend to not come, or to not come for very long. I'm sure some of that is caught up in some of the diagnoses being on the younger age of the spectrum, but also just the issues of what other life events are going on at that time compared to the older populations.
Okay, thank you. I have another question. Who first thanks you for a great talk. Did you screen by both CO monitoring and questions, which I assume is asking if they were smoking or not? Were the data collected for clinical care or research purposes?
So our intent with using the CO monitors was that they would be used clinically. So they are used in the usual clinical screening progression. Everyone who comes into cardiac rehab is screened as part of their onboarding, I believe during either their first or second session. So these CO monitoring and the CO screening is being done for clinical purposes. And what I've been told is that yes, they're asked both about their smoking and also screened, although they may not happen at exactly the same time. There may be a week or so between those, but smoking status generally is asked about very regularly anyways. So it is possible that some of the CO monitoring, for example, is picking up on people that had reported, maybe like a week ago that they had been former smokers and then they had since relapsed. But for the most part, really is a way to help identify those people that you should at least follow up with. I mean, I think that was one of the really nice things about using CO monitoring, is that it really is something you can use to screen everybody and without really any judgment, because you can explain it as, here, we want to screen you for exposure to a gas that is cardiotoxic that comes from other sources. I mean, mostly it comes from smoking. But so it's a way, and then you can use that to talk with other patients. So if you have a non-smoker with an elevated CO level, you can follow up with them and be like, where is your carbon monoxide exposure coming from? So it's being used clinically, and I really think that it's been going very well as far as adding important information while also being fairly low burden.
Okay. 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 I guess I have a question. So the cardiac rehab world is very grateful and has benefited from your studies. What direction do you see your intervention trials taking? Which is another way of me asking, what topic do you think you should write your next grant on? Intervention trials.
I think I touched a little bit on that. I really would like to work on improving smoking cessation in patients after hospitalization. That's a major one. But I think, as you mentioned, that we just really need to continue to innovate around ways that we can deliver, if not cardiac rehab, a cardiac rehab-like experience to people that can't make it into our traditional cardiac rehab world. Obviously, this is an outpatient program that it has limited hours, and it has various levels of inflexibility, and program availability differs in different areas. And so anyone who struggles to access care is going to struggle to access cardiac rehab. So it's just one of those other continuing on my mind things is how to improve secondary prevention in the folks that may not be able to benefit from traditional cardiac rehab.
Okay. I think we're set with questions and answers. That was a terrific talk, Diann. Thank you. And this was our last talk of the current series. I believe we're back in September for the next round of VCBH talks. We already have most of our slots filled with excellent speakers. So again, Diann, thanks for a terrific talk. Thank you all for attending. And looks like we'll wrap it up at this point. Okay.
All right. Thank you all.
Thank you.